Welcome to the August 12, 2020 regular meeting of the Washington Hospital Healthcare District Board of Directors. To comply with Alameda County's orders as revised on June 18, 2020 to slow the spread of COVID-19 and reduce the rate of transmission by sheltering at home and continued social distancing, this meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. Governor Newsom's Executive Order N-29-20 explicitly waives the Brown Act provision that requires the physical presence of members, the clerk, or of the public as a condition of participation in or quorum for a public meeting. We continue to comply with the Brown Act in providing dial-in information in order to provide the public the opportunity to attend the meeting. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. I see on the agenda, well, we're now going to do the roll call. So, Dee, please take the roll.
Director Wallace?
Present.
Director Nicholson?
Present.
Director Yee?
Present.
Director Epen?
Present.
Director Stewart?
Present.
Okay, well, thank you all. We will now move to our consent calendar. The consent calendar consists of those items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any actions are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? Okay, may I have a motion to approve the consent calendar items A through E?
Mr. President, in accordance with district law, policies and procedures, I move that the Board of Directors approves the consent calendar items A through E.
Thank you. May I have a second?
Second.
Thank you. Dee, would you please take the vote?
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Epen?
Aye.
Director Stewart?
Aye.
Thank you. All that the motion passes. So now we're going to move on to communications. I want to say that the members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public attending this meeting who would like to speak? Hearing none, we will continue with the agenda. Dee, are there any written communications?
There are none.
Okay, thank you then. Kimberly, I think we'll move on to the presentations.
Yes, thank you. It is my pleasure this evening. You will see that we're going to be talking about our stroke program, and you can probably see we have a number of members of our stroke team at Washington Hospital that are present tonight. And we also have Joanne Pineda. She is the Director of Quality Outcomes Research and Analytics with the American Heart Association. And she is going to be presenting Washington and the Board of Directors tonight an award that we have earned. But before that, we have Dr. Jack Rose, who is the medical director, and he's the co-medical director of the stroke program with Dr. Kulsa, and he is going to give an overview of 2019 of our stroke program. And so I am going to turn that over to him, but I just want to first introduce Dr. Rose. I think many of you know him, but he joined Washington Township Medical Foundation in early 2014. Dr. Rose received an undergraduate degree from Stanford University and his medical degree from Columbia University's College of Physicians and Surgeons. Dr. Rose received his medical and neurological training at New York Presbyterian Hospital, where he was selected as chief resident. He did a 2-year neurocritical care fellowship at the University of California, San Francisco. He is an expert in neurointensive care and cerebral vascular disease, and was among the first 100 physicians in the world to become board certified in neurocritical care. He is also board certified in neurology as well as vascular neurology. As I mentioned, Dr. Rose is co-medical director of the stroke program with Dr. Khalsa. All right, Dr. Rose, I'll turn it over to you.
Great. Thank you very much, Kimberly. Can everybody hear me?
Yes.
Yes.
Okay. Excellent. So again, thank you, Kimberly, for the introduction, and thank you to the whole board for allowing us to again give you an update, a highlight of our stroke program here at Washington, for which we're very proud. And we wanted to present a review of our stroke program in 2019 for you all, like we do each year, followed by the presentation of a well-deserved award that the American Stroke Association has bestowed upon us. So I'm going to proceed just with a programmatic overview, and I'd like to also first acknowledge that this presentation was put together by Maria Nunez, our stroke program coordinator, who's on the call with us as well. And she is just one of the amazing stroke nurses that we have the fortune to have in our program. So next slide, please. Oh, there we go. Great. So like Kimberly mentioned, I'm one of the co-medical directors of the program together with Dr. Khalsa, and we have 4 neurologists here on staff that take care of our stroke patients and grow our program. Those include Dr. Singh, Dr. Khalsa, Dr. Kalon, and myself. And Maria Nunez, who I mentioned, is our stroke program coordinator. We're thrilled to have her join this role after many years of her work as a critical care nurse in our ICU. And she additionally has a nurse practitioner degree to go along with her multiple certifications. Next slide. As you probably already know, we have a unique and very strong stroke program structure here. And the hospital, we're one of the few places in the country, if not the world, that have 24-hour dedicated stroke nurses, many of whom have national accreditations and beyond basic nursing licenses and certifications. This is one of the backbones of how we can provide such excellent stroke care to our patients. We also have neurologists, neurointensivists like myself. We have several neurosurgeons, including one that is a fellowship-trained vascular neurosurgeon. And we additionally have interventional radiologists to cover stroke interventional call. And our program is led by our stroke coordinator that has nurse practitioner certification. Next slide. We have very patient-centered stroke care here. It's multidisciplinary. It involves a coordination of people from EMS, the 911 system, our amazing ED medical and clinical support staff, the dedicated stroke nurses, which I've mentioned, our pharmacists, our neurologists, radiologists, whole radiology department, as well as our dedicated nursing and other support staff throughout our hospital, as well as rehabilitation therapies, both inpatient and outpatient. And all of these disciplines are involved in the care of a single stroke patient at Washington Hospital. Next slide. And like I said, it's a cross-functional teamwork approach, and we work very hard to maximize and optimize communication and collaboration, and work on optimizing and streamlining very aggressive and efficient, appropriate stroke care for all of our patients as fast as we can appropriately and safely give them therapies for stroke. Next slide. How do we guide the program and disseminate our data about our program? Well, we have a monthly stroke review committee that's chaired by our nurse practitioner stroke program coordinator, as well as the co-medical directors of the program. We also have members, attendees from the emergency department, radiology, from administration attend and review the data on a monthly basis. We also have a vascular and neurosurgery review committee, and I attend our critical care committee, a monthly meeting. We have a presentation about our program annually to the Quality Steering Committee, the QSC Committee, as well as to the Board of Directors, which I'm doing for you again today. Next slide. Our stroke patient volume here at Washington has remained remarkably stable over the last 10 years or so. When we first became primary stroke center certified in around 2007, we did see an uptick in the number of stroke patients that came to our hospital system, but that was before other stroke centers developed in the area. But we remain at an annual stroke volume between 450 and 500 stroke patients per year. That includes both the blocked artery strokes, which is about 80 to 85% of our stroke patients, and hemorrhagic strokes or bleeding strokes, the less common subtype of stroke. But we see both of the main types of stroke and take excellent care of them all. And despite other stroke centers advertising and being able to take care of patients throughout the Bay Area, we remain with a very good volume of stroke patients coming to our system. Next slide. Our procedural volume in terms of neuroradiology services, we've broken down over the last 3 years. We've seen an increase in the number of thrombectomies. That's a radiology procedure where a catheter is put through the groin up to a blocked artery in the brain or the neck or both, and the clot is extracted through that catheter in a minimally invasive strategy. This has become a therapy, an evolving therapy for more and more stroke patients, and we are hoping to increase this volume even significantly more in the future with the ongoing neurointerventional services we're able to provide, and with some advanced imaging technologies that we just acquired to enhance our accurate diagnosis and find patients that would benefit from this procedure. The second column is showing you are the volumes of our coiling and clippings for broken aneurysm patients that have bleeding in their brain, their fluid spaces. That's called the subarachnoid hemorrhage, and we are we are a center of excellence for treating ruptured aneurysms as well as unruptured aneurysms. And these are done by either open surgery with a clip that's put in or through a minimally invasive coiling strategy through a tiny catheter, like is done for the thrombectomies. And our volume has gone up in 2019 compared to the last 2 years prior, where we had 15 cases, and we're hoping to grow this volume as well. And in terms of other procedures, we've shared with you some data about carotid stents. This is another procedure that's occasionally performed instead of carotid endarterectomy for select patients when they have severe narrowing of their carotid arteries. But that procedure, we don't expect to have any growth in volume because it's become less commonly indicated for prevention of stroke, especially in patients that are not having symptoms. But we do hope to continue and increase the volume of appropriate carotid surgeries for patients, and maybe next year we'll share the data for that. Next slide. How about our outcomes? How well do our patients do after they're diagnosed with a stroke here at our hospital? Next slide. So one of the ways that we look at our compliance and our outcomes is that we follow our programmatic performance by looking at clinical guideline measures. One of these is a program called Get With The Guidelines. It's overseen by the American Heart Association, American Stroke Association, and they identify these 10 measures where a high performance with these measures indicates high quality care. And the goal is to be above 85% compliance with all of these measures. And if you look at the 2019 calendar year, of all of these measures, we are well above the 85% target goal. In fact, most of the measures were in the high 90s or 99 to 100%. And these include such measures as giving detailed education for patients and their families, giving a clot-breaking medicine when it's indicated as fast as possible, preventing blood clots from developing in the legs or the lungs once an admitted patient is brought to the hospital with certain kind of preventive medicines, starting them on a stroke prevention therapy within 2 days of admission, discharging them on a similar type of medicine at discharge, counseling them about smoking cessation when appropriate, giving them a particular type of cholesterol-lowering medicine at a high dose on discharge, as well as making sure that patients with atrial fibrillation, one of the leading causes of stroke, especially in our aging population, that get discharged on appropriate aggressive anticoagulation therapies, that we screen stroke patients for swallowing difficulties, and that we assess them for rehab. And you see that we've performed exceedingly well in all of these measures throughout the last year. Next slide. This is just a breakdown of one of those measures over the last 10 years, showing you that for patients that come in with stroke and happen to have this cardiac arrhythmia, atrial fibrillation, or atrial flutter, that we are very, very good over the last 10 years at maintaining a very, very high level of compliance with making sure that patients get discharged on appropriate or anticoagulant therapy, 99 to 100% for the last 5 or so years, an improvement over maybe some 10 years plus. Next slide. What about functional outcomes of our stroke patients? We don't just care about saving patients' lives with stroke. We also care about their quality of life and what kind of disability they're going to have to be facing after their stroke, and how can we optimize their recovery, both in the short term and in the long term. And one of the ways that we measure functional outcomes is a scale that's called the modified Rankin scale. And it's a standard industry-wide standard used to measure outcomes by interviewing patients or their families about what symptoms and or disability level they are at that time of interview. And a score of 0, 1, 2, or 3 out of 6 is typically equated to a good functional outcome. 4, 5, or 6 is a bad outcome, 6 being death. 4 and 5 are 2 categories of severe disability. And if you look at our outcomes on discharge from 2019, you see that 60% of our patients have a good outcome. That means that they're at worst have some symptoms but can walk unassisted. 60% of our patients on discharge have a good outcome, whereas 40%, the red pie, do not yet have a good outcome. But if you compare that to all other California hospitals, you'll see that only 27% of the patients overall have a good functional outcome at discharge, and 73% will have a bad outcome at the time of discharge. So we're doing quite well with regards to other hospitals in terms of short-term functional outcomes. Next slide. How well are we doing in giving the one medicine that is approved for treatment of blocked artery stroke, the most common type of stroke, within the first several hours of stroke onset? That medicine is called TPA. It's a clot dissolving medicine, and it needs to be given within 4.5 hours from when the symptoms started. And we don't just want to give it to patients within 4.5 hours of when their stroke started or when they were last seen normal. We want to give it to them as soon as possible after they presented to our emergency department. And our 2019 goal was to give 75% or more of our patients this drug within 60 minutes of hitting our door in our ER. And that's no small feat, because we have to do blood tests, imaging tests, evaluations to make sure that it's safe and appropriate. But you'll see that over the last 10 years or so, whereas in 2009 to about 2012, we did not have a large percent of our patients receiving TPA within 60 minutes of ED door arrival. But since about 2013 through now, we've done a much better job and have a much higher percentage of our patients getting this drug within an hour of presentation. And in fact, in 2019, you'll see that we almost achieved a 90% ability to give this drug within 60 minutes, which was better even than 2018. And that little dip down in 2018 probably reflected our move to the new pavilion and our new emergency department. Next slide. we're not just interested in getting the drug given within 60 minutes. We're also trying to even bring that number down to 45 minutes or even less if possible, which is challenging. And our goal in 2019 was to try to get that around 50%. We didn't get above that rate. And again, these are small numbers. So you'll see the numbers down here in 2019, for example, we had 21 patients that got this drug. 41% of them got it within 45 minutes. And we're hoping to try to get that closer to 50%, which is our ongoing goal for the next few years. Next slide. One of the things that has allowed us to rapidly treat our stroke patients and has improved the speed for which we treat our stroke patients has been the development of our Code Neuro system, which is an overhead paging alert system that identifies stroke patients in our ER as fast as possible. So if any patient shows up in our emergency room, either via 911 or walking in, that looks like they may be having a stroke, we call an overhead code neuro. And this rapidly allows our ER doctors, our stroke nurses, and our imaging technologists and pharmacists to be on the alert and to act rapidly to get our imaging study done and read quickly. They have our ER doctors at the bedside to evaluate the patient quickly, as well as the stroke nurse and the neurologist to get the lab results done in a rapid time so that we can appropriately make the diagnosis and decide on emergent therapies. And this has been very helpful in terms of us treating our patients optimally and achieving our excellent outcomes like I presented to you before. Next slide. Another thing we're very proud of is that we spent a lot of time not just focusing on how we take care of stroke patients in the hospital, but in terms of educating our community about what a stroke looks like, what to do if you suspect that yourself, a loved one, or bystander is having a stroke, and that is to call 911 and not wait and not come to the hospital by yourself or have a friend drive you, but to call 911. And you'll see this chart here. What it's showing you is that the green bars are our percentage of patients showing up either by EMS here or walking into our ER, either by EMS or walking in. And you'll see that from 2018 to 2019, our stroke patients that showed up in 2018 were 54% of the time by EMS, but in 2019, we increased that to 63%. So that shows the movement in the right direction. We want the vast majority of our stroke or potential stroke patients to come to our hospital or emergency department via EMS, not walking in. And you see that we had a decrease of the percentage of patients, stroke patients, coming in by just walking in as opposed to calling 911 or being brought in by ambulance. Doing so is not just theoretically associated with a faster imaging time and fasting time to the ER evaluation. That has borne out in our assessment of our stroke patients. We've demonstrated that the more likely you are to get the fastest appropriate imaging and doctor evaluation, it is associated with alerting the 911 system. So we focus on this community education to tell people to appropriately call 911 immediately, and that we will be prepared to see you immediately once you hit our doors. And now so with COVID, which I'll explain a little bit later, it's more important than ever. Next slide. How about our mortality? How well are our patients doing in terms of surviving a stroke while they're hospitalized? And this is a chart looking over the last 5 years, whereas the red bar is the stroke risk-adjusted mortality rate. So the higher the number, the higher the mortality risk or rate is. And you'll see that we are the green bar and that we are lower than all other California Get With The Guideline hospitals in terms of our mortality risk after stroke diagnosis. And our risk is 1.5 as opposed to all other hospital in California in this database at 2. So we're doing a very good job and have done a good job over the last 5 years. And we're proud of this trend. Next slide. And that's not just for all strokes, but hemorrhagic and ischemic strokes. And if you look at hemorrhages, we're also much lower than ischemic than other hospitals in terms of surviving a bleeding stroke. Next slide. How about staff education? How do we educate our staff doctors, nurses, other healthcare providers, and even the public later. But in terms of staff education, next slide, we spend a lot of time educating our team and our general medical staff and other healthcare providers about stroke. I and Dr. Khalsa give a bi-monthly stroke education series. We go over interesting stroke cases in our hospital. We go over 3 cases every month. We do it twice a month so that as many people can attend. And nowadays we do it over Zoom because we can't meet safely in person. And in fact, just this afternoon, I gave a presentation. And we find these very, very helpful. And we have doctors from ER, from neurology, from hospitalists, and many of our stroke nurses and ICU nurses, and sometimes our ER nurses attend these as well. And we're able to provide continuing education for doctors and nurses that attend. Next slide. We also disseminate education during these stroke review committee meetings, like I mentioned. In the past, Dr. Thomas or myself have given grand rounds related to neurocritical care. We last did that in 2019. We have not resumed that quite yet because of COVID, but we probably plan to do that now that we've resumed general grand rounds via Zoom. Same thing with Critical Care Skills Day. We usually include a yearly neuro presentation for that. Again, that has been on hold because of COVID, but our emergency nurses neuro huddles and code neuro simulations have continued despite the pandemic. Next slide. We also spend a lot of time educating patients and their families about what a stroke is, how to prevent the next one, and what life is going to be like post-stroke. Next slide. And we do this by providing all of them with an education booklet and education materials. We don't just hand them stuff. We do one-on-one verbal education at the bedside with our stroke nurses. We also provide information about rehabilitation, both inpatient and outpatient. We provide education about diabetes. We have our pharmacists involved in medication reconciliation, and we individualize the plan of care for every patient. Every stroke patient is not the same nor needs the same medicines or strategies leaving the hospital. We individualize it to the patient's individual risk factors and issues related to why they had their stroke so that we can optimize their recovery and prevent a second or third stroke from occurring. Next slide. What about beyond our staff or our patients? What about the larger community? Next slide. We continue to work closely with EMS so that we have a seamless acute stroke care system. We, in the past, have held stroke alert days. This has been on hold because of the pandemic. We do attend quarterly EMS meetings via Zoom now to disseminate data and to provide education for our EMS colleagues. We also submit data to EMS and offer opportunities to provide stroke education for our key partners in the EMS community. Next slide. We also have a stroke support group here in the hospital that used to meet monthly in person, and then that's been ongoing since 2007. It's led by our stroke nurses and provides an outstanding resource for our stroke survivors. And it has many worthy objectives that you can see on the screen here. We had this temporarily on hold because of COVID, but we're hoping to resume that via Zoom soon as well. Next slide. And we do lots of other things for community education. We have a quarterly stroke education series that we give educational talks with, which we plan on resuming with social distancing practices in the future. Same thing with our annual Stroke Awareness Day, where we screen patients for various stroke risk factors and provide education to the general public, which is almost always very well attended. Obviously, we haven't had that since the pandemic started, but we last did it in 2019 and had a very large attendance for this. And we have community outreach series that we've performed throughout 2019, but have not may not be able to do in 2020 quite yet. Next slide. We also, as you know, have a hospital-owned cable network TV that we can provide health education for, and occasionally some ABC News collaboration commercials that focus on stroke. And we do community presentations at times for caregivers, and we promote our stroke awareness and our program in the Tri-City newspaper publication. Next slide. What about achievements in 2019? Well, last year at this time, we were awarded the Get With the Guidelines Gold Plus Award, and we're going to be receiving a similar, if not better, award today. We continue to focus on an outstanding comprehensive stroke approach to treating all of our stroke patients. We were recertified as an advanced primary stroke center by the Joint Commission who reviewed us this past year. We were very proud of that. And many of our stroke team members attended the Pacific Stroke Association's annual conference, and we've continued participating in a pivotal carotid surgery clinical trial called the CREST-2, of which the principal investigator is Dr. Ash Jain. Next slide. In 2020, we're about to receive the Get With the Guidelines Gold Plus Elite Award for stroke. We received the first Interprofessional Team Excellence Award this year, which we're very proud of. And we've also added a brand new neurointerventional radiologist to our neurointerventional team. In fact, he just finished his first case just this afternoon. And so we're happy to add Dr. David Carrington to our team. Next slide. This is the Interprofessional Team Excellence Award that we received, and this is the picture of us socially distanced with masks in our brand new Morris Hyman Critical Care Pavilion lobby. And this award was given to us because we exemplified the positive outcomes that can occur with a multidisciplinary team working together in a timely and effective manner. And we were proud to be the first recipients of that team award. Next slide. What about our goals for the next year? We're looking to improve our door to needle time. That's the time from when a patient hits our emergency room until they get that clot breaking medicine. You see that we've done a great job of doing it within an hour. We're working on getting it closer to 30 to 45 minutes. And again, this is going to be a little bit more challenging now because of COVID. It takes us a little bit more time to safely assess patients and get some of the tests that need to be done relative to COVID, but we're still going to work very hard to decrease our door to needle times. We also are going to be focusing on increasing the volume of our procedures to take out blood clots that are blocking large arteries causing stroke through procedures and to follow the updated guidelines published in 2019 to increase the candidacy for such procedures. We also have some of our stroke nurses participating or plan to participate in a neurovascular fellowship degree program where they will spend several months to advance their capabilities to work in a higher capacity in terms of evaluating stroke patients and to work more like mid-level stroke care providers together with the neurologists. And in the future, we're very eager and interested in moving to the next level of stroke center certification through the Joint Commission, either through thrombectomy capable stroke center or even comprehensive stroke center certification. And that was one of the reasons why we added some imaging technology and a new neurointerventional radiologist to help us meet the qualifications for these advanced levels of certification. Next slide. And like I mentioned, now is more important than ever that stroke patients in the community or suspected stroke patients come to the hospital. We, like our cardiology colleagues, did notice a significant drop in our volume of patients coming to the hospital with stroke during the beginning of this pandemic. And it's not like strokes weren't happening, but patients or their family were afraid to come to the hospital. And we've spent a lot of effort, and the hospital has, of course, to reassure patients that we're ready to take care of patients during the pandemic, and especially for emergency medical conditions like stroke or heart attacks. We still want patients to come to the hospital as soon as possible and not to delay care given this pandemic. And so we've spent a lot of time on educating and advertising such. Next slide. And again, we will continue to help educate the public about how to notice, how to recognize a stroke, and using mnemonic devices like the BFAST system, which stands for balance anytime somebody has acute balance problem, anytime the patient, E for eyes, has acute visual loss or visual change, F for face, anytime their face droops or their smile suddenly becomes uneven, A for arm, and if someone's arm is suddenly weak, especially on one side, that could be the sign of a stroke. If their speech suddenly gets slurred or they can't talk or understand things, that could be a sign of a stroke. And then T for time is that 911 should be called immediately. Don't try to self-diagnose or wait for any of these concerning symptoms to get better before calling 911. And we have a very nice website with all of this information on it to educate the public and to highlight our stroke program. Next slide. And that's it. So thank you very much. And I think we have a representative from the American Heart Association next.
Yes, we have Joanne Panetta, is the Director of Quality Outcomes Research and Analytics with the American Heart Association. I think she is on.
I am.
Janet, are you there?
I am. I'm going to share my screen and let me know if you see it. Do you see my screen?
Yes.
Yeah.
Well, good evening, everyone. My name is Joanne Pineda, and I'm the Director of Quality Outcomes Research and Analytics for the American Heart Association. Thank you for the opportunity to join me today virtually. I would like to share that, this is the best part of my job because I get to celebrate with you and get to celebrate your accomplishment and celebrate the true meaning of the award, which is improved care and patient outcomes. On behalf of the American Heart Association and Get With the Guidelines program, I'd like to congratulate Washington Hospital Healthcare System for achieving another banner year of stroke accolades since joining Get With the Guidelines in 2006. Tonight, there are several. First, like Dr. Rose already had mentioned, is the Gold Plus Target Stroke Elite Honor Roll Award for implementing Get With the Guidelines Stroke. And the steps required to achieve gold level of recognition are a minimum of 85% compliance in the achievement measures for stroke for the 2019 calendar year. And the plus level requires additional data collection for a set of quality measures at 75% or above compliance. In addition, Washington Hospital achieved the Target Stroke Elite Honor Roll Award. And to qualify for this level of recognition, hospitals must meet a minimum of 85% compliance in door-to-needle time in less than or equal to 60 minutes. Lastly, this is the inaugural year that the American Heart Association implemented a recognition platform geared towards the management of diabetes treatment for stroke patients. And Washington again received the Target Type 2 Diabetes Honor Roll Award. Just to mention a few folks, I'd like to especially thank Dr. Rose and Dr. Khalsa for their leadership as identify Get With the Guidelines physician champions and stroke program medical co-directors, to Stephanie Williams and Kimberly Hart for their support as executive champions. And of course, recognize your stroke coordinator, Maria Nunes, and Michael Platzbecker, the stroke director. Dr. Rhodes had alluded to a multidisciplinary approach to stroke care, and Get With the Guidelines also emphasizes that. So I'd like to say thank you to all the members, the neurologists, the stroke nurses, the emergency department staff, rehab, radiology, lab staff for all their hard work and dedication to improving the quality of care for patients. Washington Hospital will also be recognized in an ad in the upcoming America's Best Hospital edition of U.S. News and World Report. Now it's with my great pleasure to present this award here to the Get With the Guidelines Stroke Gold Plus, Target Stroke Elite Honor Roll, and Target Type 2 Diabetes Honor Roll Award to Washington Hospital Healthcare System for your commitment to quality of care. Congratulations.
Thank you very much. I also want to thank all of the staff and the physicians. That it's a truly collaborative and high quality team that ensures that any patient from our community that comes to Washington Hospital with a potential stroke gets really high quality care, and it's really thanks to that collaborative multidisciplinary approach. So, and thank you, Joanne, for the wonderful award that you bestowed on to Washington.
My pleasure.
Thank you, Dr. Rose, and thank you, Ms. Panetta, and thank you, Kimberly and team, for all the work that we do in earning this earning this achievement. So thank you.
All right.
Okay, would you like to move to the reports, Kimberly?
Sure. So again, thank everyone in the stroke team. I know that they have many of them have Zoomed on, so thank you very much.
Thanks again.
All right. Moving on to our reports, we're gonna begin with our quality report. Mary Beauron, our Chief of Quality and Resource Management, is here to present the quality dashboard for quarter ending June 30th, 2020.
Thank you. Good evening. Thank you. It's nice to be back in the virtual setting and be able to provide you with our next quality report. The report that I'm giving this evening is based on our quality dashboard. It is for quarter ending June of 2020. And while we're getting this open, just wanted to go over a couple of things that I think are significant about this quarter. This quarter takes place, of course, in April, May, and June of this year. This is a time period that is after shelter in place, and we're well into our pandemic and pandemic planning. And you'll see as I go through the slides that there are certain areas that appear to be impacted by that and process, and we'll talk a little bit more as we go through about the plans related to that. To start off with, go through the infection prevention indicators. Our central line associated bloodstream infections, otherwise known as CLABSI, did go up a little bit this last quarter. This is actually 2 central line infections, and these were patients that one had a long length of stay, and the other patient was a patient from med-surg. So no significant connection between the pathogens in their blood, but it is above the benchmark of 1.0, slightly above it at 1.2, higher predicted. And because of this, we are looking again at our central line bundle compliance and making sure that all patients who do have a central line in place have it only when totally medically necessary, and that when it is in there, it's taken care of correctly through the proper bundle precautions and hand hygiene. So we'll continue to monitor that as we've noticed this increase. Our second here is the catheter-associated urinary tract infections, otherwise known as CAUTI. This has significantly declined over the last 2 quarters. This is actually 1 catheter-associated infection, putting us below the benchmark, making us better than expected for a hospital of our size and type. Now that we're at over 2 quarters with this decrease, I think it's fair to say that some of the things that we have implemented on initiatives to reduce CAUTI are effective. One of which is we are using external devices for catheters and really looking at only placing catheters, urinary catheters, in dwelling when absolutely necessary. And we've actually looked at and implemented a couple new devices that have reduced our catheter days down. And with that, working with the medical staff and nursing, we've been able to really bring this down. I think this is a great reflection on the team working together and the bundle compliance being done well and better outcomes for patients without having to deal with having a CAUTI infection. So we'll continue to monitor that and watch the process closely for our catheter days. Also, another success here on their 4th quarter in a row where we have not had any patients get MRSA bloodstream infection. So of course, the MRSA is a very difficult resistant pathogen to treat with antibiotics. And we have had success there on not having any patients acquire it within 72 hours or greater after being admitted. The same with the VRE, the vancomycin-resistant enterococci infections, also incredibly difficult to treat with antibiotics. Second quarter in a row without having any of those identified in the patient's blood. C. difficile has continued to be a challenge. We did have a great period of time, as you can see, in 2019, where we sustained a reduced C. diff, but this is our second quarter going up. It's now at 1.3. This is a reflection of 10 hospital-associated C. diff infections, meaning that the patient was identified to have C. diff after the third day of admission. In looking back at these 10 cases, there is a group of people related from nursing to ID medical staff and infection control, and we identified that there were some cases here where we probably could have done some different testing. There are strict indications for making sure that you're testing appropriately, because there are a lot of patients that just tend to carry C. diff, and in doing that, we decided we also want to take this analysis a step further and outside of the organization, and we are reaching out to our local hospital-associated infection reduction hospital liaison. That is a liaison that has a specialty background in reducing hospital-associated infections. This is a program that is supported through our California Department of Public Health, and we just want to make sure that we get some outside resources to help us look and review our bundle, and we'll continue to look at that next quarter and give some analysis provided from that support. Moving into surgical site infections, colon surgery. This is our fourth quarter in a row where patients have not had any surgical site infections within 30 days after having their colon operated on. This is a great reflection of the care that our general surgeons offer. It's also a great reflection of what goes on in the OR here. And this can tend to be a high-risk procedure for surgical site infections. So to sustain that for 4 quarters in a row is really a good measure of the safety of our OR and the great practice of our general surgeons and OR staff. And we can apply the same thought process to the abdominal hysterectomies, another high risk for surgical site infections, which is why we look at this and have to report this on a federal, state, and local level. And we've gone to 2 quarters sustaining without any infections here. So same level of quality being offered there for that surgical procedure. Hand hygiene continues to be a challenge. We're at 89.4% for this quarter. Well, the national average for hand hygiene sits around 70%, and Joint Commission's goal is to have us at 90%. Internally, our goal is 100%, and we're continuing to strive towards that. We were able to continue to collect hand hygiene data during this period of time, and we are actually doing a further analysis on this, because now more than ever, we would expect to see great hand hygiene compliance, and in coordination with all the other precautions we're putting into place with COVID response planning, hand hygiene we actually did expect to be higher. And as a result, we are actually expanding the hand hygiene observers, and myself and the Chief of Compliance and Patient Safety Officer will be going out and doing some extra investigation on this, and just to make sure and validate further our hand hygiene. We will continue, obviously, to include this as the hospital initiative, as it's a large part of our COVID response planning. Moving into our nursing sensitive indicators, 2 quarters in a row here, we have not had any patients that fell and sustained an actual injury. This is also a good measure of rounding frequently on patients, identifying fall risks early on, and making sure that patients that are at risk are in visible areas. And I think we're seeing some of that result in good outcomes for patients. There is a dotted line on this benchmark here, and that is in relation to the fact that the National Database for Nursing Quality Indicators actually has a benchmark that they provide that trails a little bit behind how quickly we would like to bring this information and share it. So because of that, we are using the benchmark of 3.24, which is the latest available one from NDNQI. but the dot just signifies the fact that as they continue to update their benchmarks based on their national comparative data, that is subject to change. So, but again, 0 injuries are good. And this next slide is an example of something that has been impacted during COVID, and that is our hospital-acquired pressure ulcer injuries. Typically what we do is anytime a patient comes in and is admitted to the hospital, they are 100% of the time assessed, their skin is assessed from head to toe and documented very carefully. And this is a nursing standard that we continue to follow and have followed through COVID response planning. However, in addition to that, we do have another trained nurse that goes in and conducts studies that are based on NDNQI guidelines and standards. And that is what this slide typically reflects. Because of COVID response planning, there have been national guidelines provided on how often a healthcare worker should enter a room and who should enter. And as I'm sure you would agree, the only people that should be entering these rooms are ones that are absolutely necessary. And therefore, the NDNQI guidelines recommended that the studies were not conducted during this period of time. So that's why it's NA. So we do not have a pressure ulcer update. However, as of July 1st of this year, now that we have more safety measures and policies and procedures in place related to COVID, that did resume here at Washington Hospital, and so the next quarter it will be reflected. Moving into our readmission rates, this is another example of an area where we have been working on readmission reduction efforts, but during COVID planning, of course, these initiatives and the resources allocated for them were shifted into COVID response planning as the hospital steered towards making this the safest environment possible for healthcare workers and the patients. So readmission initiatives have started again, and our meeting has started again in June, and we are revamping and revisiting all of those initiatives. However, during this period of time, some have been impacted by COVID. Starting off with pneumonia, as you can see for this quarter, our readmission rate, which is at 18.5, was above the CMS national benchmark, so which means that 15 patients came back within 30 days of discharge out of the 81. That denominator is one of the lowest denominators we've seen, obviously, because during this period of time, we were seeing less patients being admitted to the hospital, which is part of why the rate is more likely to be high. In addition to that, with pneumonia, this is a diagnosis that, of course, we're seeing more of, and the 15 patients that came back some of them were considered what we call patients under investigation, PUIs. So we don't know much further than that other than about what's caused this slight increase. But this will be one that we'll continue to monitor based on revisiting these CMS reduction interventions for pneumonia. AMIs, otherwise known as a heart attack, this did go down significantly for the patients that were readmitted to the hospital. The actual denominator of 30 patients over the quarter is not much lower than what you can see in the past quarters, like 36 and 39. However, the number of people who came back within 30 days of discharge is less. It's only 3. And this is, of course, good. It does bring us under our benchmark because we only had a 10% readmission rate, and the CMS national benchmark is 16%. However, again, because, as I think you heard Dr. Rose mention earlier, there are a couple of service lines where we did see less patients, and cardiology is one of them. So I think that it's only fair to say that this readmission rate was possibly impacted by the fact that less cardiology issues were possibly being readmitted to the hospital. Heart failure, we did have 15 patients out of 67 who were readmitted, putting us at a 22.4% readmission rate, slightly above the national benchmark of 21.9. Of these heart failure patients, we looked closely at them and to see if they were possibly somehow related with COVID. 20% of these patients did have COVID, so it's not too significant of an impact, but this will continue to be the area that we focus on primarily with our hospital readmissions reduction efforts, because it tends to be one that we struggle and is over the benchmark. So these patients, we're going to be looking really closely at making sure that they are receiving phone calls after they go home, especially right now with patients being at home, and we want to make sure that they have the support services and are getting the medically necessary treatments that they need. So we are doing follow-up phone calls on all of these patients and directing them and helping them get the support that they need and the medical care that they need after discharge. Patients that have coronary artery bypass graft also was up slightly above the benchmark. The denominator is 5, and 1 out of the 5 patients came back, putting us at a 20% readmission rate. This patient absolutely did require being readmitted to the hospital, and it related to some complications with bleeding, and the patient ultimately did have a good outcome, but was medically necessary for them to be here, and so that is a slightly above benchmark. With our primary total hip replacements and total knee replacements, I think this is well known to be a service line that offers great outcomes to patients. We continue to see that again. This is the 6th quarter under the benchmark, and we actually, out of 48 procedures over the quarter, did not have any patients readmitted. So that's another great reflection of the quality of care being provided with that procedure. COPD patients, chronic obstructive pulmonary disease patients, we did have 5 patients return out of 16, putting us at 31.3%, which is above the CMS national benchmark of 19.6. Of these 5 readmissions, they are actually 2 patients, but combined they equal 5 readmissions. 1 came back 3 times and the other one came back 2 times. These patients were high risk for readmission, actually determined to be very high, have chronic illness, complex cases, absolutely needed to be in the hospital to have that managed, and we will continue to monitor those patients as needed. But again, it's a small number in this case. No, that's it. Thank you. Any questions?
Okay, well, thank you, Mary. Kimberly, you want to continue?
All right. Next is Chris Henry, Vice President and Chief Financial Officer. He is going to give the finance report for June.
Hi, and just waiting for us to get the file up here. Okay, so June ended up as a pretty good month, a good way to end an otherwise difficult year. Looking at our operating indicators, you know, a lot of our volumes around admissions, patient days, average daily census continued to be lower than budget. Average daily census was 22 below budget, admissions 172 below budget, and patient days 662 below budget. Outpatient observation equivalent days, however, were 46 above budget at 186. So had a lot of folks in the house, just not necessarily admitted. Average length of stay for the month was pretty close to budget at 5.05. We had expected 4.94. Looking at our utilization, case mix index for the month spiked up in June at 1.539. We expected 1.490. And again, I think some of that's reflective of some of the discussion Dr. Rose had about patients really waiting too long to come to get services. So when they do show up, they're really quite ill. Deliveries for the month were 4 below budget at 114 in June. Surgical cases were pretty close to budget at 380, just 2 off of expectations. That includes our joint replacement cases that were 24 above the budget at 163. We had 8 more neurosurgical cases than expected at 31. Cardiac surgical cases, again, cardiac services seem to be coming back slower than other services, 5 below budget at 6. Cath lab procedures for the month were 70 above the budget at 417. Outpatient visits were off a little over 1,000 at 6,196. And that was largely driven by x-ray and cardiac rehab. And the emergency room saw 5,355 patients, 1,251 more than expectations. Almost exactly half of those visits, however, were related to COVID testing. So normal emergency visits were well below budget. A quick look at Cath Lab activity. As I noted, cardiac activity in the OR is slower coming back. Likewise in the Cath Lab, that's really the takeaway here. Cardiac procedures making up 32% of the volume, and peripheral vascular making up 46%. Under normal conditions, these two generally run pretty close to one another, but we're still seeing that gap as cardiac comes back slowly, more slowly. Looking at our full-time equivalents, productive FTEs for the month were 44.5 above budget at 1,313. Again, we are carrying some additional FTEs to deal with the issues directly related to COVID. A lot of those are out in our tent where we're doing the COVID testing, and also the screeners that we have at all the doors, making sure everybody that comes in is healthy and safe. Non-productive FTEs for the month were 31.5 below budget, so we end up with total FTEs for June that were 13 above the budget at 1,461.7. Our full-time equivalents per adjusted occupied bed for the month were 0.37, higher than we expected in the budget at 6.84, but that's really a big improvement over what we have seen the last couple of months with FTEs per AOB up in the 7s, and I think that is related to our increased levels of activity in June. Moving into the financials, and again, this is our Governmental Accounting Standards Board presentation. We always start with this one. This is the presentation used for our audited financials. Gross patient revenue for the month came in $3 million lower than budget at $166,072,000. Our contractuals for the month came in at 76.88%. We'd expected 77.65%, and here's the breakdown. Really, we did have a favorable payer mix in the month with our government-sponsored patients making up 69.6% of gross revenue. We had anticipated 72% in the budget. PPO, likewise, was higher than budget at 25.6% versus a budget of 23.2%. So that was a very favorable payer mix for us, drove our contractuals lower than expected. Also, our provision for bad debt and charity came in pretty close to budget, just slightly lower for the month. And their makeup of gross revenue was pretty close to what we had expected in the budget. Moving on to operating expenses. So we end up with net revenue for the month, actually $1.8 million higher than budget at $40,120,000 as a result of that favorable payer mix. Operating expenses, about $1.1 million lower than budget at $37,850,000. That variance almost entirely driven in our benefits area. Health and welfare claims for the month came in $221,000 lower than budget, and our pension and OPEB adjustments that we've been taking drove pension and OPEB expense about $967,000 below budget. So we end the month with operating income for the hospital that was $2.9 million higher than budget at $2,270,000. Non-operating income for the month, a lot to talk about here. We've been talking about, the elephant in the room is that $28.7 million in federal subsidies. We've been talking a lot about that money and have not budgeted, have not booked it up until June, pending more guidance from our auditors and from the federal government. We still have not gotten clear guidance on that, but felt like we needed to book this money. Based on what we know today, we believe we qualify for all of it, but as we go through our audit and as things progress and more information is available, we may need to be making some adjustments to that, but we didn't feel we could not book it based on general accounting principles. Also in there of note is the $32,000 loss on our rental activities. We had in June received notification of one of our larger, well, I think our largest renter in Fremont Office Center, that would be Peterson Dean, declared bankruptcy in June. So we had to book about $170,000 reserve against the money they owed us. We were really stuck. There was no way to evict them given the current orders from the county. So, but they did declare bankruptcy. And we also made some provisions for some of our other tenants who have asked for financial assistance during this period. We booked about another $53,000 for those. We are trying to work with the tenants as best we can, and hopefully we'll get through this and retain most of them. We did have an unrealized gain on our investments in the month of $138,000. And a realized gain of $90,000 in the month. So we end up with non-operating income at a little over $28.8 million and a total bottom line, including that federal subsidy money, of almost $31.1 million. Taking a look at our Financial Accounting Standards Board presentation. This is the way the financial markets may adjust those financials we just looked at when they look at us. We reclassify the revenue bond portion of interest expense back up into operating expenses. That's where FASB classifies it, to end up with operating income about $3 million higher than budget at $1,539,000. And then we eliminate the income and related interest expense for our general obligation bonds in non-operating income, and also eliminate our unrealized gain on investments to come up with non-operating income, again, of $29.1 million, and a total bottom line from a FASB perspective of $30,680,000. We'll take a quick run through our earnings before interest, taxes, depreciation, and amortization. And for folks not familiar with this, we look at this to kind of get an idea of how much income the operation is generating for the payment of interest expense and future capital needs and other programmatic needs. We do that by eliminating we look at income prior to non-cash transactions, the biggest one of those being depreciation. So when we do that adjustment, we end up with EBITDA of about $6.5 million, a vast improvement over what we've seen the last couple of months. Likewise, we like to look at our non-operating interest, our non-operating income before interest expense. That's showing the $30,696,000. But if we factor out the federal grant money, really our non-operating operations generated another $1.9 million in income. So in total, we're looking at, between EBITDA and non-operating activities, generating about almost $8.5 million in income, again, for the debt service on our bonds and future capital and programmatic needs. So are there any questions on June's results?
No, I don't think there's any questions. So why don't you proceed with the operations report?
Okay.
All
Right. I'm going to be presenting the preliminary operations report for July. I think that just a theme you will see here that we've actually in July saw fewer admissions, but the patients were sicker, and we had a longer length of stay, and a great deal of that was driven by our COVID patients. But to begin with, you can see gross revenue of $181.1 million for July was above budget by $13.7 million, or 8.2%, but below July of 2019 by $15.3 million, or 7.8%. So inpatient gross revenue of $118.9 million was above budget by $12.7 million, or 11.9%, but $16.2 million below July of 2019. Outpatient gross revenue of $62.1 million was above budget by $1 million, or 1.7%, and $1 million, or 1.6% above July of 2019. And some of that, again, is, as we've talked about, we've seen the shift of joints, and now hips have also shifted to outpatient. Moving on to key census statistics, our average length of stay of 5.65 was above the budget of 4.95 by 0.70, or 14.1%, resulting from the higher acuity of patients seen, particularly, as I mentioned, the COVID-19 patients that had an average length of stay of 9.38 days. The average length of stay was also longer than that in July of 2019, which length of stay was at 5.29. And we also saw the Medicare case mix index was high at 1.94. 74, and the total case mix index was also high at 1.61. So as you can see, as I mentioned, we had longer lengths of stay, and the patients were sicker. Our outpatient observation days were 11, or 6.4% above budget at 184 days, and our average daily census of 158 was above the budget of 139 by 19, or 13.3%. Going on to admissions, admissions were below budget by 40, or 4.6%. Admissions for the month were 189, or 18.5% below July of 2019. Patient days of 4,898 were above budget by 576, 13.3%. And for the month, they were 586, or 10.7% below July of 2019. Moving on to our surgical trend, our total surgical cases in July of 357 were below budget by 25, or 6.5%, and the surgical cases were 14.2% below July of 2019. So I think what we've seen is sort of that leveling off of the backlog that we saw in May and some of June. Our inpatient surgeries were 20, or 10.3% below budget at 174, and 29.6% below the July 2019 volume. Outpatient surgeries were 5, or 2.7% below budget at 183, but 8.3% above July of 2019, and again, I think that's we're seeing that shift in joints. Now looking at the surgical activity broken down, our joint replacement surgeries were below budget by 16, or 9.8%. Our general surgical procedures were below budget by 7, or 3.7%. Our cardiac procedures were below budget by 5, or 45.5%. And our neurosurgical procedures were above budget by 3, or 15%. But again, I think we're continuing to see some of our patients still having some anxiety in terms of coming into the hospital for procedures. And it's important as we continue to get the word out about how safe it is at the hospital. All right, our Cath Lab Trend. Our Cath Lab procedures for July of 422 were 44, or 11.6% above budget, and 2.7% above July of 2019. Our inpatient Cath Lab procedures were above budget by 12, or 5.2%, at 245, and 17.2% above July of 2019. Our outpatient Cath Lab procedures were above budget by 22.1%, but below the prior year by 25, or 12.4%. So we did see a nice rebound in our Cath Lab volume. Looking at the Cath Lab activity broken down, you can see non-vascular interventional radiology procedures were below budget by 10 or 12%. Our neurointerventional radiology procedures were on budget. Our cardiac procedures were above budget by 12 or 9.4%. And our peripheral vascular procedures were above budget by 42 or 26.1%. Our deliveries for July of 132 were below budget by 11 or 7.7%. The deliveries were 5 or 3.6% below July of 2019, but the deliveries were 15.8% or 18 above the previous month. So we did see some upward trend in our deliveries. In terms of our non-emergency outpatient visits, this has been an area that's been specifically challenged over the last number of months. We did see some of them rebound. We saw visits of 7,268 were above budget by 99 or 1.4%, but they were still below July of 2019 by 828 or 10.2%. In terms of the breakdown, our lab visits were above budget by 10%. Our EKG visits were above budget by 114 or 108.6%. Our infusion visits have continued to be high. They were above budget by 64 or 16.8%. Our cardiac visits were below budget by 213 or 30.9%. And our X-ray visits were also below budget by 196 or 11%. Looking at our emergency room visits, this is another area that we've continued to see that has been lower than in the past. Our emergency room visits, and you'll see we split out emergency room visits compared to our RSTU, our Rapid Screening and Treatment Unit. So these are the pure emergency room visits that we're seeing in the emergency room. We had 3,302, which were below budget by 748 or 18.5%, and we're below the same period last year by 1,146 or 25.8% visits. And if you move on to the Rapid Screening and Treatment Unit, our RSTU, mainly we're doing treatment or doing screenings for symptomatic and exposures of COVID for potential COVID patients. We saw 2,762 visits, and they were above budget by 640 or 30.2%. So that number continues. We continue to see increasing numbers at the RSTU. All right, moving on to the gross revenue recap. Emergency room visits were below budget by 18.5%, and RSTU visits were above budget by 30.2%. Driving emergency room and RSTU revenue down by 4.3%. I think we've talked about in the past, the RSTU revenue per visit is not as high as our pure ED visits. Our Cath Lab procedures were above budget by 11.6%, driving Cath Lab revenue up by 2.6%. Our surgical cases were below budget by 6.5%. However, surgical services revenue was up by 1.7%. Inpatient days were above budget by 576 or 13.3%, and driving room and board revenue up by $5 million or 16.1%. And the higher level of inpatient and outpatient activity drove ancillary services revenue above budget by $6.9 million or 9.3%. All right, looking at our payer mix, unfortunately, the month of July, our payer mix was unfavorable compared to budget in a number of the areas. Our government-sponsored patient revenue made up 74% of total gross revenue, which is higher than the budget of 71.1% and higher than last year's percentage of 72.5%. Our HMO revenue was 2.6% of gross revenue, which is on budget but lower than last year's percentage of 2.8%, slightly lower. Our PPO revenue was 21.7% of gross revenue, which is below the budget of 24.3%. and lower than last year's percentage of 22.9%. And then private pay revenue was 1.7% of gross revenue, which is slightly below the budget of 2% and lower than last year's percentage of 1.8%. All right, looking at our productivity indicators, productive FTEs were above budget by 114 or 9.1% at 1,360.9, driven by the 13% increase in patient days. Our non-productive FTEs were below budget by 31 or 14.9% at 176.9. So our total FTEs were 1,537.8, which were above budget by 5.7%. Moving down to our productive FTEs per adjusted occupied bed, they were at 5.66, which was very close to the budget of 5.68. And our total FTEs per adjusted occupied bed of 6.39 were below budget of 6.62. And we even came down, I think if you remember, Chris said our total FTEs per AOB for June was at 6.84. So we did continue to focus on the FTEs per AOB. Looking at July of 2020 in terms of other operational statistics of the WASP surgical cases, the Washington Outpatient Surgery Center were above budget in July by 22 or 5.5% at 420. Our clinic visits of 2,635 were above budget by 3.5% for the month of July, but they were 20% below the July 2019 volume. So we continue to see our lower number of clinic visits. And we had Washington Urgent Care is down 161, though the Warm Springs Clinic and Nakamura Clinic were both above budget. All right, moving on to our key financial statistics in charity care. Our days cash on hand for July ended at 186 days. It was a decrease of 16 days from last month. We saw 11-day decrease due to revenue bond debt service, so we paid around $12 million in interest and principal that's due in July of every year. If you remember, we also pay around $6 million in January of interest only. The other factor in this driving our days cash on hand down was there was an approximately 8-day decrease from disbursements related to, it was a 3 payroll month in July, and that's about $9 million is third payroll, is what it costs. You can see our days of gross revenue and accounts receivable were at 63, and there were 552,105 in charity care applications pending or approved in July. So we did see that number increase some, but less than prior year. Okay, moving on to the homeless patient activity. There were 181 homeless patient encounters in July of 2020. Homeless patients with more than one encounter accounted for 27 of the 181 encounters. Estimated incremental cost of Senate Bill 1152 for the month of July is $116,000. Estimated total unreimbursed cost of homeless care for the month of July was around $288,000. And you can see, just this is a recap of fiscal year 20. For that year, estimated total unreimbursed cost of homeless care for fiscal year 20 is $5.9 million. Then you can see the breakdown in terms of the activity. There was a significant decrease in avoidable days, in which drove down the estimated unreimbursed homeless cost for July. You can see the red portion of the bar represents the monthly estimated incremental cost, and the yellow portion represents the monthly total estimated unreimbursed cost. And on the number on top is the total number of homeless encounters for July, which was 181. All right, that is, any questions for the preliminary operations report for July?
Okay, well, thank you. Kimberly, do you have any announcements that you'd like to make at this time?
I just have a couple of announcements. I do just want to make sure that the board and the community are aware that We are doing community outreach events in an effort, to continue to provide education and support to our community. We have revisited the formats of our presentations, and we are hosting community health seminars now on Facebook, YouTube, and Zoom, so that our community can access education safely from their home or other places. So if anybody in the community is interested, they should go to our website, www.whhs.com/events, or you can sign up for a seminar or call 800-963-7070. And we've had some really good events over this last month. On Thursday, June 18th, Dr. Martin, infectious disease specialist, and Mary Boron, our chief of quality and resource management, presented Reduce Your Risk when phasing out of shelter in place. We had 39 community members participated in the live event, and then 304 people have accessed the presentation since that time. On July 2nd, we had Sharmi Mukherjee, who's our Director of Outpatient Wound Care and Rehab, and Mark Nevis, Occupational Therapy Physical Therapist, did a presentation on staying fit while working from home. We had 46 community members that participated in the live event, and since that time, 194 people have accessed the presentation. We also had Dr. Saw on August 5th. As an orthopedic surgeon, he presented Don't Let Hip Pain Win on Facebook Live and YouTube. We had 93 community members participate in the event, and since that time, 190 additional people have accessed the presentation. So I just encourage the community to go to our website to look at the seminars that are being presented. I also do want to say that I want to thank the community. We've had, our community continues to support the healthcare system in many ways during this challenging time. The foundation received many in-kind contributions of food, personal protective equipment, and monetary donations in the month of July. The trustees would like to thank the following donors: the Swell organization for donating 2,000 water bottles, Maker Nexus for 11,000 3D printed face shields, Dr. Bruce Lynn for isolation gowns, coveralls, and masks, the Fremont Youth Emergency Preparedness Council, Sisters of the Holy Family, Supsky Foundation, Lamb Research, Fremont Bank Foundation, East Bay Community Energy, Cliff Bar, and the Buddhist Tai Chi Foundation for many other donations of PPE. Our thanks also goes to the following restaurants who are providing meals to our frontline staff: Carmen and Family Barbecue, Zarian's Restaurant, Vitality Bowls, Round Table Pizza, Pizza Guys, Fremont Bank, and Massimo's, Spin a Yarn, Bo 7, Beijing Bowl, and An Hua. So we very much, I know the staff very much appreciates all the food and all this outpouring of support that the community has shown for our physicians and our clinical staff. And then lastly, I do want to mention that the U.S. News and World Report generates hospital rankings by evaluating data on nearly 5,000 hospitals. And I'm excited to let everybody know that the U.S. News Report recognized Washington Hospital as a high-performing hospital in hip replacement and knee replacement this year. So I have that. And then lastly, I also just want to recognize our Employee of the Month for August, and that's Felix Zepeda. And he is working at Washington Hospital as an environmental service aide, and he's been here for 31 years. Felix, a Washington Hospital baby and current Fremont resident, has enjoyed getting to know people throughout the hospital and interacting with different types of patients. For the past 2 years, Felix has worked in the IJRR. Felix says that working in the IJRR is special because of the great team, and that team is happy to have him. The charge nurse there says Felix is an integral member of our IJR family. He goes above and beyond to keep our unit clean and help staff with everything in the department. The unit would not be able to run as smoothly as it does without all of his hard work. He's also willing to train new employees, offering tips and advice on how to best complete their tasks. No doubt his positive attitude for the past 3 decades has made Felix one of the few Washington Hospital employees who have received the honor of Employee of the Month 2 times. All right. Those are my announcements.
Okay, thank you, Kimberly. Any comments from board members or questions? Okay, we will, hearing none, we will now go into a closed session. However, before doing so, I want to let the public know that they will have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want the members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you. The board will now adjourn to a closed session.